I am privileged to an episode of our Health Talk series organized by the Student Council of Sadhabai Raisoni Women's College, supported by SGR Knowledge Foundation and powered by Raisoni Group of Institutions. Good sexual and reproductive health is a state of complete physical, mental, and social well being in all matters relating to the reproductive system. A woman's reproductive system is a delicate and complex system in the body. It is important to take steps to protect it from infections and injury and prevent problems, including some long term health problems. For many years, gynecologic cancers have held an erroneous reputation for being silent, the types of cancers that are not preventable or detectable until it's too late, and only limited treatment options are available. Today, we're joined by Dr. Richa Bansal, a reputed senior consultant gynecological oncosurgeon who also specializes as a laparoscopic and robotic surgeon at Apollo Hospitals in Navi, Mumbai, with an experience spanning nearly a decade. She is considered to be a key opinion leader in this field within the medical community. After her MBBS and MS in obstetrics and gynecology, she pursued her super specialty training in gynae cancer at the prestigious and renowned Tata Memorial Hospital in Mumbai, where she worked for 7 years. Her surgical expertise is in performing all the supra-major gynecological oncological procedures, including open, laparoscopic, and robotic surgeries for gynecological cancers, as well as radical and major surgeries for cancers of the ovary, uterus, and female genital organs. She also treats women with familial hereditary cancers and offers genetic counseling and testing. In addition to performing cancer surgeries, she is passionate about raising awareness for the prevention of cancer and has been invited to speak on the same on both national and international platforms. In her words, she is committed to deliver the best possible care and treatment to women with gynecological cancers and also to have a dedicated HIPEC and robotic program. Ma'am, a very warm welcome to you and many thanks for joining us today. I'd like to hand over the session to you, please.
Thank you so much, Afra, for that kind introduction.
You're welcome.
Let's move on with the slides. So my field of expertise is managing gynecological cancers, and this would be the topic of our talk today. So definitely cancer is preventable, and with all of us joining hands together, we can definitely work towards ending it. So this is something which I always quote, and I really firmly believe in this, that when you educate a man, you are educating a man, but when you educate a woman, you educate an entire generation. The onus of, inculcating good habits in the family, in the children, lies mainly with the women. And, we are majorly responsible for, taking care of the entire family. Children, they try to emulate what we do. And if they see that, we take care of our health and especially do not neglect our health, then definitely they would inculcate the same. So when we talk about cancer, I'm sure there are numerous questions that rush in your minds about what is cancer, what causes cancer, what is the basic reason behind it, and how is it diagnosed, treated, and so on. So cancer is basically uncontrolled growth of cells within the body. Normally, cell division and millions of cells are multiplying each second, but this growth or this division is very much in control of the body systems. But cell division in cancer is uncontrolled, and it's really just out of control of the body mechanisms. So a tumor or a cancer is notorious in first invading in the locals in the organ where it is arising, and then if left untreated can also spread to the other parts of the body. Like, for example, a breast lump, a breast cancer initially would enlarge in size. It can infiltrate in the local organs like chest wall muscle. And if left untreated, it can show metastasis to lungs, liver, bones, and so on. So this is why we fear cancer. So let's talk about gynecological cancers. Certainly, gynecological cancers are a very important public health problem in India, with a huge load of cancer in women being in the genital organs. What is even more important to note is that in India, majority of the gynecological cancers, and for that matter, majority of the cancers, of the majority of the common cancers which are seen in our population, are diagnosed in locally advanced or in advanced stages. Cancer is a common diagnosis. In fact, there are few cancers which are much more common in Western population as compared to Indian. The main difference is, or where we are lagging behind, is that in the more developed world or in more educated societies, cancer is being detected early, and hence its treatment is more effective. Most of the cancers are curable. Where we are lagging behind is that majority of our women present when the cancer has already been there for some time, when they have already been suffering from symptoms for quite a significant time, and only when their symptoms worsen, they are not relieved, and only when their health really deteriorates, it's only then that they present to us. So majority of the cancers that we are diagnosing in our country are in stage 3 and 4, meaning when the cancer is already infiltrated into the surrounding tissues, or has even metastasized to other organs. And when the cancer is being diagnosed in more advanced stages, definitely its treatment would be more complicated. Treatment protocols would be more complicated. A lady who has been diagnosed with a stage 1 cervical cancer is certainly curable with just radical surgery alone, vis-a-vis when she is diagnosed with locally advanced cancer or stage 3 or 4. The treatment protocols are more complicated, meaning she may require combination of radiation also, chemotherapy also, sometimes surgery also. And even then we may not be able to guarantee cure. We may only be able to control the cancer for some time. And this is the reason, where the morbidity of treatment, mortality of cancer is significantly high in fact, in all middle and low income countries. And this is where we need to work. And what can we do to bring this down is be more aware of these symptoms, and not to ignore when one is experiencing the common symptoms that I would talk about. Another problem with gynecological cancers is, the majority of the menstrual problems are, a taboo. I mean, women do not want to discuss their menstrual problems with their family members. A mother may be too shy to discuss her menstrual problem with her son or with her daughter-in-law. A lady who has already stopped her periods may be experiencing postmenopausal bleeding, which ideally is really abnormal and should be immediately investigated. But we notice that majority of these old women, they come to the doctors late. They're too shy to discuss these problems with their family, and by this time the cancer has already reached from stage 1 to stage 2, 3, or even 4. So now coming to the cancer of the cervix. Cervix is the mouth of the uterus or mouth of the womb. And cervical cancer is the second most common cancer that affects women in India. In fact, it was the most common cancer affecting Indian women just a few years back. And now breast cancer has superseded cervical cancer, but still in many states, many rural areas or many pockets of India, cervical cancer ranks still as the number one or the most common cancer affecting Indian women. And the irony is that though at one point I'm saying that cervical cancer is so common in India, it is also a preventable condition. It is in fact one of the very few preventable, completely preventable cancers of the body. And we will discuss why I'm saying that cervical cancer is preventable. Now let's first, see the cervical cancer disease burden in India. And this, will sensitize us about how major this problem is and, why it is so important to understand the preventive aspects of cervical cancer. So as I said, cervical cancer is the second most common cancer in women in India. And, even more importantly, it is the second most common cancer affecting women in the age group of 15 to 44 years. We all can understand that, this is the age group where, a woman's life is most productive. She has young kids. And she is very, very important to her family, especially her children. And when and this is the age group which is most commonly affected by cervical cancer, and and it's very disheartening to see young women losing their life to cancer, to cervical cancer. So, of course, India accounts for almost 25% of all cervical cancer cases and deaths worldwide. In fact, majority of the cervical cancer cases are being diagnosed in middle and low income countries. And India is, one major country which bears the major brunt of this problem. And this is why it is so important for us to understand this problem. So, if we'll go deeper in the statistics of cervical cancer in India, it's even more scary. We have more than 67,000 deaths from cervical cancer annually. Almost 185 women die of cervical cancer every day. Approximately 8 women die every hour of cervical cancer, and a woman dies every 8 minutes. So, initially, childbirth, when a woman used to go through the process of pregnancy and childbirth, it used to be, said as a second rebirth of the woman, because the mortality was so much high during, pregnancy and childbirth. But of late, deaths due to cervical cancer have even surpassed deaths due to pregnancy. So, I always put this picture so that all of us remember that, cervical cancer is actually caused by a virus. And it was Professor Harald zur Hossein who discovered that cervical cancer is caused by human papilloma virus. And for that, he was awarded a Nobel Prize in 2008. We all know that, hepatitis B is the virus which affects liver, and it can cause liver cancer, hepatitis B virus and hepatitis C virus. So similarly, cervical cancer is also caused by a virus. It is actually a sexually transmitted virus. It is actually it is the most common sexually transmitted infection affecting a young couple. And, and this is the main reason of cervical cancer. So why do I say that cervical cancer is preventable? It is because we have two very effective tools which can protect us against the HPV virus and its consequences, which are HPV vaccination and cervical screening with cytology. Of course, I will deliberate on all of these points in detail. So now, like I said, cervical cancer is caused by human papilloma virus. It's a sexually transmitted infection. Whenever a young couple starts their sexual debut, almost 90 to 100% of the couple will get infected with HPV in the next 6 months to 1 year. But also, with the help of body's immunity, in next 1 to 2 years, 90% of the women will be able to clear off this HPV infection from their genitalia. So it affects, but it also gets cleared. It is only in those 5 to 10% of the women who, due to various reasons, are not able to clear this HPV infection from their genitalia, and who continue to harbor this persistent HPV infection in their genitalia. These are the women who are eventually at higher risk of developing cervical precancer and cancer. And hence, like how we have hepatitis B vaccine against hepatitis B. Hepatitis B vaccine is now a very important component of a national immunization schedule. Similarly, we also have a very effective and safe vaccine against HPV. There are 2 brands available, Cervarix and Gardasil. Both of them are international brands. Both of them are equally effective, equally safe. The most ideal age group to take this HPV vaccine is between 9 to 15 years. Like any other preventive vaccine, childhood is the time. It is the best time for vaccines because the level of immunity is higher, and also the immunity which is provided by the vaccine when the vaccine is given in childhood, it's also more lasting. So same is true for HPV vaccines. The most ideal age group is adolescents between 9 to 15 years. The next best time, if a girl has missed this window of 9 to 15 years, the next best time is to vaccinate her before she's exposed to sexual intercourse, and or before her marriage. And this is it. And the good news is the cost of this HPV vaccine, which are these Cervarix and Gardasil, the international brands, is between 3,800 to 4,200 single dose, and 2 to 3 doses are required for vaccination. And the good news is that now we have our Indian manufactured indigenous vaccine, which is produced by Bharat Institute of. It was recently launched in the month of November, and it has received the permission of large scale manufacturing, and in next few months it will be freely available in all our major pharmacies, and the cost will be between 200 to 400. So this is something which we were really waiting for, our own vaccine, which would be less costly, so that it can benefit a wider population. So definitely HPV vaccination is the first tool that we have. And the second one is cervical screening with cytology, or what we commonly know as pap smear. The ideal age group for pap smear is between 30 to 65 years of age. Along with pap smear, now that we know that cervical cancer is caused due to HPV virus, we can also test the cervical smear for HPV test. So basically, it's a simple examination, can be done by any gynecologist in her OPD. Just requires 5 minutes, no anesthesia, nothing, just a part of it is part of a routine examination. Now what we do is we collect the cervical smear, and then we examine it under the microscope to see if there are any abnormal cells in the cervix. Cervix sheds cells in the secretions, and these are the cells which we can collect, form a smear, study them under the microscope to see if there are any abnormal changes in those cervical cells. And this is how we can diagnose cervical precancer or cancer much earlier than when a woman would actually have more advanced problem, she would have symptoms and so on. And with pap smear, along this cervical smear can also be tested for the presence of HPV virus. So if a woman shows persistently positive HPV in her cervical smear, we know that probably she is having persistent HPV infection, and we keep her, we evaluate her further, and we keep her under long-term follow-up. So these are the tools. For young girls, we have HPV vaccination, and for married women between 30 to 65 years of age, we have pap smear and HPV test. If we are doing both these tests, then if today a woman's both the tests are normal, the next interval is after 5 years. So, it's actually very convenient, very cost effective. It is not that these tests need to be done every year or every 6 months or so. If both the tests are positive, negative from a good laboratory, then the next interval when a woman needs to repeat the test is actually 5 years. Now, another thing that is important to understand that there is a long pre-invasive state. A woman acquires HPV infection when she's, probably in early 20s or somewhere in her 20s, sometimes even earlier. And the common age group, in which cervical cancer affects is late 30s or early 40s. So, which means that we have fairly, 12 to 15 years of interval between, infection with HPV, which is the causative factor, and development of cancer, which is the ultimate outcome. So we have long 12 to 15 years of time when we can actually detect whether HPV infection is causing any abnormal changes in the cervix with the help of pap smear and HPV test. So even if a woman misses to do her pap smear or HPV, or if she doesn't start the screening at 30 years of age, she may get herself screened at 35 years, 38 years. Even then, we would be able to catch these women who may be harboring some abnormal changes. And this again, imagine this situation, and contrary, if the causative factor would had taken very less time to progress into cancer, then it would have been very difficult for us to catch these women. So this is the importance. This is why we say that cervical cancer is preventable, because we actually have a fairly long interval when a causative factor is affecting, and then actually the cancer is happening. And also the fourth reason why I say it is preventable is because the treatment of these pre-invasive lesions, which we diagnose on pap smear, it is highly effective. And once we treat these lesions by very basic treatment methods, not at all very fancy or invasive, the risk of development to cancer is highly prevented. So this is some basic information.
Ma'am, I can't see you. I think there's a bit of a network issue, I think, from your end. I can't see you. Your screen has blanked out. And can you hear me?
Okay.
Yeah, it's better now. Yeah. I can see you now.
Okay.
Yeah, thank you.
Okay. So, I was saying that, if we are vaccinating between 9 to 15 years, then just 2 doses 6 months apart are sufficient. And if we are vaccinating a young woman beyond 15 years of age, then 3 doses, 0, 1, and 6 months would be necessary. So these are some of the slides which I've taken from WHO. These slides show the impact that screening with pap smear and vaccination can have on cervical cancer incidence and mortality. It says that if we can just vaccinate all our girls, we will be able to bring down cervical cancer mortality by almost 44%. And the impact of screening can be so powerful that even if a woman undergoes screening just once in her lifetime at 40 years of age, we will be able to bring down the cancer incidence reduction by 52%. And if we can even just screen her just thrice at 35, 40 and 45 years, then with just screening thrice in her lifetime, we can bring down the incidence of cervical cancer in our country. So this is the strategy developed by WHO towards, and these are the steps towards elimination of cervical cancer as a global public health problem. This is the same way we have all worked together in eliminating polio from our country by effective polio vaccination programs. So this is the dream in regards to cervical cancer as well. Now that we know that cervical cancer is caused due to infection and we have an effective vaccine against it, I think we should all work together to realize this dream of eliminating cervical cancer as well. So but for that we will have to fully vaccinate our young girls by 15 years of age. At least 90% of our young girls should be fully vaccinated before 15 years of age. 70% of our women between 35 and 45 years of age should be undergoing screening with pap smear and HPV test. And all this will work to bring down the cancer mortality by 30%. So this was this was the information that I was sharing, that cervical cancer has actually a long pre-invasive period between a woman or a girl actually acquiring HPV infection and then she developing pre-cancer or cancer. We have a significant time gap between the two, and this is where we can work in screening with pap smear and HPV test so that we can recognize these women much before they are actually developing cancer. So, these are the, though any woman who is sexually active can be at risk of cervical cancer, but there are special, risk factors which may be associated with the cervical cancer, and especially, they work to, decrease the clearance of HPV infection from the genitalia. So if a girl has, started her sexual activity before 18 years of age, because the cervix at that time is very sensitive to damage by HPV, and the epithelium, the cell lining of an organ is called as epithelium. So cervical epithelium is actually too immature to and HPV virus easily gains entry into the epithelium. And hence, these girls are at higher risk of developing persistent HPV infection and also eventually cancer. Same is true with early age at first childbirth. If the first childbirth happens before 20 years of age, again, the cervical epithelium undergoes damage at very young age, and HPV virus can gain access or penetrate the cervix far more effectively as compared to if the first exposure or the first childbirth is after 25 years of age. Of course, then if it also depends, cervical cancer, HPV virus can its effects get potentiated if a woman also has a tendency to develop other sexually transmitted infections, other bacterial or other viral sexually transmitted infections. So if she has multiple male partners, or if her partner has multiple partners, then these are the women who are at higher risk of developing cervical cancer. Women who consume tobacco in any form, because their immunity is suppressed, HPV infection clearance may be a problem in these women. And also women affected with HIV, because we all know they're immunocompromised. and also other forms of immunosuppression, some other systemic illnesses which affect body's immunity. These are the women which could be at higher risk of cervical cancer. So now that we have learned about prevention of cervical cancer, now let us know, what are the common symptoms of cervical cancer? Which are the symptoms which one should not ignore if she is experiencing these symptoms? And these could be pointing towards cervical cancer. So any unusual vaginal discharge, especially if it is foul smelling, especially if it is not responding to treatment. Also, any amount of vaginal bleeding or spotting after having sexual intercourse is highly abnormal. It suggests contact bleeding. It suggests that cervix is unhealthy, or it may be having cervical precancer or cancer. Any unusual vaginal bleeding or spotting in between normal periods. The two periods are normal, but unexpectedly on 15th day, 20th day, the woman experiences spotting. This is absolutely abnormal. Such kind of spotting is rarely due to some hormonal imbalances or other usual causes, usual reasons of menstrual irregulations. And these are the symptoms which should raise a high suspicion of having some problem in the cervix. Any woman who has stopped her periods, it may be 1 year back, 2 years back, even 5 years back, 10 years back, if she experiences bleeding or even just one episode of spotting at any point after she has stopped her periods, is abnormal. And it should not be ignored. One cannot wait that, okay, if the bleeding will increase or spotting will become more often, only then I will consult. Even if there is one episode of just spotting, even then it is abnormal and needs consultation. So early cervical cancer may not produce any symptoms. Very early cervical cancer may not give rise to any of these symptoms, and usually symptoms occur only when the growth has become, when the tumors has enlarged in size, or if it has become more advanced. So these early cervical cancer sometimes we diagnose when a woman is undergoing regular screening. So we detect some abnormalities in the pap smear, HPV test comes as positive, and then we investigate further. Sometimes we find very early cervical cancer, and this is how cancer can picked up really early if a woman is regularly screening herself. So now coming to treatment for cervical cancer, for that matter, treatment of any organ of the body, if it is diagnosed in stage 1, treatment is curable, with just surgery or just, radiation. Surgery is usually the mainstay of treatment for early cancers of, any part of the body in general. And in contrast, any cancer of the body, if it is diagnosed in more advanced stages, treatment will be less effective. It will be more complicated. Complications, side effects of treatment will be more. Also, cure rates cannot be ensured. So, stage 1 cervical cancer is potentially curable with just surgery alone. Surgery entails not just simple removal of the uterus, but it's radical hysterectomy. It's a proper cancer surgery with proper lymph nodal dissection. So it is not that, okay, uterus or the mouth of the uterus has some problem and get us and just let us get the uterus removed. That is not the solution. That is the wrong treatment, incomplete treatment. It requires proper radical surgery. More advanced stages, surgery is not possible. Treatment requires radiation, chemotherapy, and so on. Hence, it is very important that cervical cancer is picked up early and also treated appropriately. So now coming to the second gynecological cancer, which is ovarian cancer. Ovarian cancer is actually the second most common gynecological cancer affecting Indian women, though its incidence is much less as compared to cervical cancer, but nevertheless, it is a significant problem still. In our OPDs, ovarian cancer patients are very common. The typical ovarian cancer, it affects women in their 50s and 60s. But nowadays, we are observing a rise in the incidence of ovarian cancer, especially in younger women. And the main reason for the rise in ovarian cancer in younger women is history of infertility, delaying marriage, delaying first childbirth beyond 35 years, having less number of children, not really breastfeeding for 6 months or 1 year. So all these factors, they are hormonally interlinked, and somewhere all these factors, also overweight. So being overweight, infertility, not having children, or having her first child after 35 years of age, not really breastfeeding the children, having less number of children. Nowadays, most of us are restricting to just one kid. So all of these are somewhere putting the women at risk of ovarian cancer and also uterine cancer. These two are the cancers which are hormonally linked, and these are the factors which are in subtle way responsible for increased incidence of ovarian and uterine cancer, especially at younger and younger age, which we were not observing before. Conventionally, our textbooks say that ovarian cancer, uterine cancer occurs in postmenopausal women, but no, nowadays we are really observing rise in younger women as well. So ovarian cancer is considered to be the deadliest among all gynecological cancers. It grows really fast. Majority of these cancers are very aggressive, and by the time the diagnosis happens, the cancer has already spread in the abdomen to also other organs. And this is why we call it deadliest cancer. Also, we call it a silent killer because there are no specific symptoms that can help diagnose ovarian cancer early. Stage 1 ovarian cancer means when the ovarian cancer is confined only to the ovary and it has not spread anywhere. Now, since ovary is a part of abdominal cavity, and since abdominal cavity can accommodate, even if one ovary enlarges in size, it's not necessary that it will really give rise to a lot of symptoms, because abdominal cavity has potential space, and even if ovary is enlarging, it can accommodate. It may not give rise to a lot of symptoms quickly, or even if it is causing symptoms, they are really very vague. Like just because a heavy ovary or enlarged ovary is causing pressure on the urinary bladder, the patient, the woman may just feel that her frequency of passing urine has increased, or she may just feel little pressure or heaviness in the lower part of the abdomen, or sometimes she may feel constipation, that 2 months before her bowel habits were absolutely normal, but since last 2 months she's feeling little constipated. Or or sometimes the symptoms are like gastritis, indigestion, which can be easily attributable to many other reasons, like, okay, 2 days back I ate outside and that is why I'm feeling little gas or bloating, or such symptoms in the abdomen. So these there is no symptom that is really specific to ovarian cancer, and hence majority of the women, they present late. Sometimes even if they present to the doctor, general physicians, they may not suspect ovarian cancer with these really very non-specific symptoms. They may just prescribe them some symptomatic medications to relieve her bloating and all, and they may not really investigate in the lines of ovarian cancer. This is why majority of the ovarian cancers that we see are diagnosed in more advanced stages, and diagnosing ovarian cancer in early stage is really difficult, and hence it is called the cancer that whispers, that only gives subtle indications and nothing really strong and specific. And it is also called a silent killer because it's silently, ovarian cancer keeps on growing inside the body without raising any alarm, and by the time it gets diagnosed, it is little advanced stages. So like I said, early stage ovarian cancer rarely causes any symptoms, and even advanced stage ovarian cancer symptoms are so non-specific. Many a times patients, they have first consulted in the gastric department, gastroenterology department. They were undergoing evaluation over there for some, bloating, or for some, constipation alternating with loose motions and so on. And then after many investigations, the ovarian cancer gets picked up. So, very non-specific symptoms. So signs and symptoms of ovarian cancer, they include abdominal bloating or swelling, quickly feeling full when eating. That, in 2 months back, I was eating at least 2 chapatis in every meal. And since last 2 months, after having even one chapati, I feel as if I've eaten so much. Something of that sort. Weight loss, discomfort in the pelvis area, discomfort or feeling of pressure, heaviness in the lower abdominal area, changes in the bowel habits like constipation, frequency of urination. These are the symptoms that can point towards ovarian cancer. Now, what are the risk factors of ovarian cancer? Risk factors means, which are the factors that predispose a woman or increases a woman's risk of developing ovarian cancer. So one thing is old age. Like I said, conventionally, ovarian cancer is the diagnosis of older women in their 50s, 60s, after they have achieved their menopause. And, in younger women, it is less, traditionally, it has been said that it is less commonly seen. But nowadays, because of the reasons I quoted, we are definitely seeing rise in the incidence even in younger age. So one thing is, and other thing is inherited gene mutations. Some of these women, have hereditary cancer syndromes. They have very strong family history of breast cancer and ovarian cancer in many of their close relatives. So these are the women who are definitely at higher risk of ovarian cancer, knowing one's family history, that, okay, what had happened to my, mom's sister or mom's sister's daughter, or, paternal aunt, father's sister. I mean, being aware of one's family history is extremely important. So like I said, family history of ovarian cancer, breast cancer is very important. Some forms of hormonal replacement therapy, which are commonly used for menopausal symptoms, they also may be the reason for ovarian cancer. So how is the diagnosis made? So whenever a woman presents some of these with some of these vague abdominal symptoms, an ultrasound of the abdomen and pelvis is the first investigation that is usually done, and it is generally prescribed by a general physician. And when that ultrasound shows that, okay, there is ovarian enlargement, there may be some free fluid in the abdomen, and so some changes, and this is how the ovarian cancer gets suspected. And then on further investigations by further specific investigations by an expert leads to ovarian cancer. Since I said that, the symptoms are so non-specific, and because ovarian cancer is so lethal, we always advise our fellow general doctors that, you should, it is always better to err on the side of caution, even if there is no strong reason to think that a woman could be ovarian cancer. But if she's presenting with some vague abdominal symptoms, always get an ultrasound of the abdomen and pelvis. It is far better rather than missing out on doing the ultrasound and then the woman presenting after some time with ovarian cancer. So if there is any suspicion of ovarian cancer, one must consult an expert, which is gynecological oncologist, for further evaluation and treatment. So this was in short about ovarian cancer. Now coming to uterine cancer. Uterine cancer is a cancer that begins in the body of the uterus. This is separate from the cervix. Cervix is the lower part of the uterus, which we call as mouth of the uterus. And uterine cancer, it starts in the body of the uterus. And the good part of uterine cancer is that generally it is diagnosed at an early stage, because even at very early stage, it gives rise to symptoms, which is abnormal vaginal bleeding. Usually, like I said, uterine cancer is found in older women, usually after they have achieved their menopause. So a lady who has already achieved her menopause, who has already stopped her periods, she will experience bleeding or spotting, and this is how she presents to the doctor, and then the diagnosis is made. So generally, we diagnose uterine cancer at early stage, But of course, if a lady has neglected her symptoms for very long, of course, it is not very infrequent that we diagnose uterine cancer in more advanced stages as well. So, the symptoms are vaginal bleeding, especially after menopause. In a premenopausal lady, in a lady who has not achieved her menopause and is experiencing her regular periods, the very typical symptom will be heavy periods. She will say that before 6 months, my periods used to last for 3 to 4 days with moderate blood flow, and I was not really troubled by the bleeding. Since last 6 months, the periods are heavy with passage of clots. I get very weak. I feel very weak during the first 3-4 days. And also the periods are lasting for longer period of time. So initially, if they were lasting for 3 to 4 days, now they're lasting for 6 to 7 days. So this is the typical history given to us by the woman. And this is when we suspect that, okay, there is something abnormal. Same thing we advise our general physicians also, that whenever a lady presents to you with such symptoms, before prescribing her symptomatic medications to just decrease her blood flow, we also need to suspect uterine cancer. And and how will we evaluate them? It is always better to do one biopsy, uterine biopsy, before just letting them go with just symptomatic medications. If they will have some symptomatic medications, bleeding will reduce, but that's not the main treatment of the underlying problem, like that. Or some kind of pelvic pain, heaviness, congestion in the lower, this thing. So what are risk factors, or who are the women who are at risk of uterine cancer? One thing is age, more common in older age. Other factors are those hormonal factors which I talked about: obesity, then a lady who has never been pregnant because of many reasons, infertility, or having just one kid, delaying her first childbirth beyond 35 years of age, and so on. PCOS, a lot of you all must have heard of PCOS, which is polycystic ovarian disease. Girls with polycystic ovarian disease, some of them can be at high risk of developing uterine cancer later in their life. Especially in these girls, uterine cancer develops at a relatively younger age. I have treated 32, 33 years old with history of PCOS, some history of irregular periods, getting periods every 3 to 4 months. And when the periods used to come, the periods used to be very heavy, or the periods used to come only after taking some medications. So this is a very common history, which we correlate with the diagnosis of PCOS. And this is a very common history in these young women who develop uterine cancer at relatively very early age. I had even 29-year-old who was treated for uterine cancer. So like I said, the incidence of uterine cancer is surprisingly coming down, especially in these obese girl who has history of irregular periods. And she should always be counseled about her increased risk of uterine cancer, never to ignore any heavy bleeding and so on. So again, like I said, we always have to think about uterine cancer, even in young women, who are having PCOS, infertility, delayed childbirth, having less number of children. And also diabetes in older women, or even women in their 40s, 50s, diabetes, hypercholesterolemia, abnormal lipid profile, high cholesterol in their blood levels. So these are the factors which are linked to uterine cancer. And how can one prevent uterine cancer from developing? First and foremost is maintaining a healthy weight, maintaining an active lifestyle, avoiding sedentary lifestyle. So that is most important. Also taking some kinds of birth control pills. These birth control pills or contraceptive pills, because uterine cancer, ovarian cancer, these are, somewhere hormonally linked. These contraceptive pills, they tend to correct our hormonal imbalances. They tend to restore our hormonal milieu. So, these birth control pills, they have an added advantage that if they are taken for a reasonably good amount of time, 2 to 3 years, they can decrease that lady's risk of developing uterine cancer as well as ovarian cancer in future. So, this is one advantage which every woman should know. So now, again, coming to uterine cancer diagnosis, early diagnosis is the key. Whenever a lady comes to us with abnormal bleeding, we always get a biopsy done. Biopsy is generally done under some kind of sedation in operation theater. Sometimes it can be done in OPD as well. And that helps us in diagnosing uterine cancer. Treatment of uterine cancer is very effective with the removal of the radical hysterectomy, removal of the uterus, ovaries, and also complete lymph node dissection. And this kind of cancer surgery we are also performing by laparoscopic and by robotic route, and without hampering the oncological safety, without as compared to open methods, these methods have also shown equally good survival outcomes. And of course, we all know what are the advantages of robotic surgery and laparoscopic surgery. They are all minimally invasive surgery. The surgery is done by very tiny cuts on the abdomen as compared to a big cut that is used in the open surgery. So blood loss during surgery is less. Patient is able to come back to her daily routine much faster as compared to open surgery. She can resume her work much faster. Discharge from hospital is much faster, much earlier, and so on. So these are the advantages of robotic route. Laparoscopic route as compared to open route. But of course, at the same time, I would like to highlight that every cancer surgery cannot be done by robotic route. The case selection criteria, or to be able to give the benefit of robotic surgery, case has to be selected very carefully. The first and foremost motive is to achieve long-term survival outcomes. If to achieve long-term survival outcomes, if open surgery is the best, we do open surgery. If same outcome in those selected few cases can be achieved by laparoscopic or by robotic surgery as well, then of course we offer laparoscopic and robotic surgery. So this is the message that I want to give. Many patients come to me asking for robotic surgery, and even for very some scenarios where it's absolutely not feasible, absolutely not advisable, they insist on doing robotic surgery. So this is not right. Let your doctor decide what is best for you, considering many things: your type of cancer, the organ that the cancer is affecting, what is the stage of cancer, what are the findings on your CT scan, on your PET scan, how far the cancer has spread. So many criteria are to be considered when we are deciding on whether to offer open surgery or robotic surgery. So we cannot compromise on the survival outcome. Robotic surgery is offered only when same job can be done by the open route also, and as effectively by the robotic route also. So this is the point that I wanted to highlight. So this is the end of my presentation. I've covered 3 of the most important gynecological cancers. Other less common cancers are cancer of the vulva, or cancer of the outer of the external genitalia, or the perineum, which we call. The cancer of the vulva is actually rare. It forms only 5% of all gynecological cancers. But of course, in our practice, we do see it commonly. The common symptom is, feeling of a lump or a lesion or some abnormal area on the perineum, which is, giving rise to a lot of itching, sometimes bleeding, and all. The diagnosis is by biopsy, and the same thing holds true here also. If it is early stage, it will be curable. If the lady has presented to us early, it will be curable. If she has ignored her symptoms for a very long time, if the stage at presentation is more advanced, then we can only promise control, and sometimes cure is not possible. So this is about cancer of the vulva. Cancer of the vagina is even rare, and treatment is most commonly by radiation. Common symptom is again abnormal vaginal bleeding. Mostly it happens in older women. So these are the common gynecological cancers. I treat, of course, all of these cancers: cervical, uterine, ovarian, vulval cancer. I do not treat breast cancer, so that is a separate topic. Usually, and that again requires a lot of. That's again a separate topic. So, thank you
Yeah,
very
that
much.
was wonderful. You're most welcome. Thank you. It was an absolutely, I would say, eye-opening session as well. A lot of things that we would tend to ignore and just dismiss them as hormones, they could have very drastic implications. So I do have a few questions for you on this. If you could maybe unshare your screen and then we could have you. Yes, yes. So, firstly, before I really speak about all the cancers that you've spoken so in depth about, I want to ask you about a thing that you specialize in aside from robotic and laparoscopic surgeries, which is HIPEC, HIPEC. Could you maybe speak a little bit about that?
Yes. So, see, the treatment for ovarian cancer is by surgery. It's a special kind of surgery. We call it cytoreductive surgery, meaning that whatever disease we find in the abdomen, we have to remove all of it. Ovarian cancer, especially when it is, more advanced stage, when it has spread little beyond the ovaries, it can spread to the peritoneum lining, the inner lining of the abdomen. Like outside we have skin, the inner lining is called peritoneum. Also, the lining which is covering all our internal organs is called peritoneum. So ovarian cancer has a propensity to give rise to a lot of deposits, lot of lesions everywhere. It's like chicken pox, small lesions everywhere. So it has, predilection of affecting or giving rise to multiple deposits all over on the peritoneum, also on the intestines. There is a fat curtain hanging from large intestine, which is called omentum. It can spread to the lymph nodes, the regional lymph nodes. So, lot of things can get affected. The cancer for ovarian cancer, it's not just removal of the uterus and ovaries. It is much more than that, much more detailed procedure, much more advanced procedure than that. So, as you can understand, that ovarian cancer can spread anywhere in the abdomen. So the treatment is removal of all those deposits. Whatever disease we find after opening the abdomen, all of that has to be removed and followed. And the surgery is followed by chemotherapy. Usually we give 6 cycles of IV chemotherapy that is given intravenously. So, in an attempt to improve the survival from ovarian cancer further, because I mentioned it's quite a deadly cancer, it's quite an aggressive disease. But, since it remains confined to the abdomen, the idea is to be able to directly deliver the chemotherapy where it is, required the most. So, with the help of HIPEC, which is called hyperthermic intraperitoneal chemotherapy, means we are delivering the chemotherapy in the abdomen at a slightly higher temperature of 42 to 43 degrees Celsius, and we circulate this heated chemotherapy inside the abdomen at the end of our surgery. So once we have done the surgery and the abdomen is still open, we circulate this chemotherapy for about 90 minutes cycle. So, the chemotherapy comes in direct contact with the tumor cells, and, the chemotherapy can stay in the abdominal cavity for longer period as compared to when we give it with IV route. And also the systemic toxicity can be less. The systemic side effects can be less because we are giving the chemotherapy right at the area where it is required the most. So this is the advantage of HIPEC, that we are actually targeting those microscopic tumor cells. Whatever the eyes can see, the surgeon is expected to remove all of that with the help of surgery. And those microscopic tumor cells, which are probably remaining behind even at the end of a successful cytoreductive surgery, these are the microscopic tumor cells that we want to target with the help of HIPEC, because these are the cells that that are hypothesized that these are the cells might be responsible for causing a recurrence or a relapse. So despite the most radical surgery, despite the complete chemotherapy regime, recurrence in ovarian cancer is quite common. And this recurrence is thought to be because of these microscopic cells which are remaining behind. So HIPEC is an attempt to target these microscopic tumor cells with the help of chemotherapy, which we are delivering directly inside the abdomen. So this is the idea of or rationale of HIPEC.
Okay, thank you, ma'am. So, just to speak a little bit about the cervical cancer, which for which you offered a very detailed explanation. I read a statistic that, cervical cancer is on a very dramatic rise in women over 30 as well. And as you mentioned, it was linked to early sexual activity, with multiple partners, which could cause HPV transmission. So, what is your advice to young girls who may not be taking necessary precautions?
Yes. So first thing that I want to clear is, though we say that cervical cancer is caused by a sexually transmitted virus, and it is more common in girls who have, started their sexual activity fairly young and who may be having multiple sexual partners, still the most common scenario that we see, or the majority of the women that I see in my OPD are, just like our normal women who never had any multiple sexual partners, who got married at the right age, and who always have been in a monogamous relationship. So first idea is that any married woman can be at risk. It is not that only a woman should not think that, okay, I am I am in a monogamous relationship, I got married at a young age, I do not have any of those typical risk factors of cervical cancer, so I should not be going through pap smear screening and HPV test. Of course, those are a few select high risk group, but again, when we are reading the statistics of cervical cancer, that it is so common, all of those cervical cancers cannot be happening in only those kind of women. So the most common category of patients of cervical cancer that we see are normal women, like like we see in everybody's household. So every lady has to screen her with pap smear and HPV test. Every lady is at risk, and every mother should think about getting her girl vaccinated. Again, we cannot think that cervical cancer is common only in those selected groups, so why should I get my girl vaccinated with HPV? And again, coming to your question, sorry, what was it? Can you please repeat it?
I said, what would be your advice to young girls who may not be taking necessary precautions?
Yes, so of course, vaccination and pap smear apart, these two strategies and these two things we have to advocate. Apart from this, of course, healthy sexual practices, using a condom, then not starting the sexual debut before 20 years of age, and avoiding multiple partners. These are the things that we would recommend.
Okay. And ma'am, I also read that, in ladies with AIDS, the risk of cervical cancer is sixfold as compared to women who do not have AIDS, for example. So how is it that they can prevent that risk maybe, or, is the vaccination going to come in handy in this scenario as well?
Yes, you said that right. Cervical cancer is one of the AIDS defining illnesses. and women with the HIV infection, or those who have, and more so those who have full-blown AIDS, they are at extremely high risk of developing cervical cancer. In fact, we see that these women develop cervical cancer at much younger age as compared to women who do not have HIV, and also they tend to have more aggressive disease. Yes. So the main reason for this is HIV virus causes immunosuppression, and this potentiates the effect of HPV. It facilitates the entry of HPV in the cervical epithelium. It prevents the HPV virus from getting cleared from the genitalia, and it potentiates the carcinogenic or cancer producing effects of HPV virus. And that is why we see that these women they tend to develop cancer even at younger age as compared to women who do not have HIV. And definitely HPV vaccination is very important in these women, though HPV vaccination is not the most effective way. If vaccine is given after the sexual activity, if a woman is already exposed to HPV virus, if she has already been sexually active, not just HIV, or any lady who is already married since last 2 years, she is not the ideal person to receive HPV vaccination. So again, same is true for these women. In them, screening with pap smear and HPV test are more important. And like I mentioned, that in normal women, screening in frequency should be between 3 to 5 years. In these women, it is even more frequent, and we do have national guidelines on how should we screen HIV positive women, and these guidelines suggest that these women should be screened more frequently as compared to the general population.
Okay, ma'am. So coming to ovarian cancer, which you've mentioned is a silent killer, the symptoms are not really detectable until a very late stage. So I'm assuming there's going to be some sort of hormonal imbalance associated with the cancer. So are there any physical manifestations of that people can look out for in terms of signs and symptoms? And when should they consider, having those evaluated very seriously?
Yes, so ovarian cancer, yes, it can be caused due to some hormonal this thing, but as such, there are no symptoms or signs of hormonal imbalance that can suggest that okay, this woman can be at risk of ovarian cancer. And the common symptoms that we should be aware of are the ones that I have elaborated, heaviness in the lower abdomen, increased frequency of urination, constipation, and especially if any of these symptoms were not present before. If suppose, before 1 month, none of those symptoms are there, and it's only since last 1 month that someone is experiencing one or many of these symptoms, and especially if the symptoms are not getting relieved by the common home remedies that are done, or common symptomatic medications, and especially if these symptoms are progressively increasing in severity. So then, this is the time when somebody should not ignore their symptoms, and should meet the doctor. And also the doctor should not ignore then these kind of symptoms, because when actually a general practitioner is sitting in the clinic, these symptoms can be extremely common. They must be encountering patients with these symptoms very, very commonly. So one really needs great judgment that in a lady who may be in that age bracket where she may be at increased risk of ovarian cancer. One may even try to elicit the family history, and and especially if one or multiple of these symptoms are present and have been present for some time and not getting relieved, then definitely an investigation, ultrasound should be advised.
Okay, ma'am. So, in a few of the cancers that you've spoken about, the gynecological cancers, well, of course, except uterine cancer, in which there could be a potential hysterectomy on the cards. So, what do the prospects of reproduction look like? Like, if fertility is lost, for example, can it be restored?
See, the majority of the gynecological cancers which affect uterus, ovaries, cervix, the treatment will entail removal of the uterus, some majority of the times ovaries as well. And once these organs have been surgically removed, fertility loss is permanent. But there are certain scenarios, some very early cervical cancers in a young lady with very early cervical cancer, and who really understands and who is really motivated to undergo very rigorous follow-up. We can offer her fertility preserving surgical option where we can remove only the cervix along with the lymph nodes, and we can preserve the body of the uterus. But of course, it cannot be offered to any woman who desires fertility. The case selection has to be very strict. It can be offered only to very few ones who have really very early cervical cancer, and that fits into a set of very strict selection criteria. Same is true with uterine cancer. Some young women with very early cancer and early grade 1 cancer, which is confined only to the inner lining of the uterus, that is, which we call as endometrium, without showing any invasion or infiltration into the surrounding muscle, meaning very early stage uterine cancer. We can, and especially when they are really motivated to preserve the fertility, to undergo the rigorous follow-up routine, these can be given some hormonal high-dose progesterones, high-dose hormonal medications to reverse their cancerous changes and be under regular follow-up. Similar is the case with ovary. Very early stage, when the ovarian cancer is confined only to one ovary, and when it has not spread anywhere, and especially few selected types, they can certainly undergo fertility sparing surgery where we remove only the affected ovary. We are preserving the uterus and the opposite normal ovary. But of course, for all of them, case selection criteria has to be very strict, and we should be fairly reasonably convinced that the oncological safety is not hampered.
Okay. So, ma'am, coming to my very last question for you, you did mention that ovarian cancer may have a genetic component, like a certain faulty gene that may be inherited that could trigger the cancer. So, is it fair to consider gene therapy as a potential and viable alternative to, standard modes of cancer treatment in this case?
So gene therapy is, I think, it's a very recent advance in very few selected cancers. I think certain types of blood cancer are the ones where it has really been tested. But gene therapy is, in its very nascent stage, and so far, as of now, it does not have any, therapeutic value in treating ovarian cancer. But we do have, of course, you said it right, that about 15 to 20% of ovarian cancers can be hereditary because of germline mutations in the genes called BRCA genes. And though we do not have gene therapy, but of course we can diagnose which women have this hereditary kind of ovarian cancer, and we do have certain medicines which act particularly against this genetic mutation, this genetic change, and who have shown significant improvement in survival for these women with ovarian cancer who have hereditary ovarian cancer.
Okay. So, thank you so much, ma'am, for this very long, lengthy, and detailed session. I would also include an eye-opening session, as I mentioned earlier. I hope that everyone has taken, a lot of meaningful takeaways from this session, especially with regards to getting vaccinated on time and watching their sexual activity, regulating it, or following certain guidelines to avoid the risk of cancer itself. So once again, a very thank you to you. And would you like to offer some concluding words on the same?
Yes, so be aware of these gynecological cancers, about their common symptoms. We always are in the denial that okay, cancer cannot affect us. Whenever we think of this cancer, I think nowadays we very commonly hear one of our neighbors or one of our distant relatives. But definitely, the incidence of cancer is rising. But at the same time, the developments in the field of prevention, early diagnosis, effective treatment. So there are a lot of developments also happening in the field of cancer. So definitely, this is why we can say that cancer is preventable. If somebody has already got cancer, then it is definitely curable. And with the most recent advances in the field of treatment diagnostics, we can offer cure and control in majority of our patients with cancer. We just need some awareness and support from everybody's end, that they should be aware and they should not be ignoring their symptoms. Thank you.
Most welcome, ma'am. So with this, I bid adieu to the audience watching this, and we come to the end of today's session. Thank you and good night. Goodbye, ma'am.
Bye.